Let's talk about antiphospholipid syndrome. Background. There's 3 antibodies contribute to the diagnosis of APS. Lupus anticoagulant. It is reported as present or absent, not quantified. Usually we, on the lab, we check for lupus anticoagulant sensitive activated partial thromboplastin time. The next one is anti-cardiolipin, either IgG or IgM. Usually you see a 40 GPL or MPL will be positive. Then it's anti-beta glycoprotein 1. On the lab you see an SGU or SMU at 99th percentile. Usually we need 2 tests positive 12 weeks apart to diagnose APS. Or you can have clinical diagnosis 3 or more, less than 10-week pregnancy loss, 1 greater than 10-week pregnancy loss with normal fetus, or 1 preterm delivery less than 34 weeks due to preeclampsia or other placental insufficiencies. Medical complications of APS, venous and arterial thrombosis. 70% are venous. 2% of DVT patients is positive for APS. 25% will have a recurrence of thrombosis if they're not treated. Pregnant patient with APS has 10% risk of developing DVT. Stroke involving the MCA middle cerebral artery is the most common artery involved. Transient ischemic attack and amaurosis, Fugax is also associated with APS. Also, we can have autoimmune thrombocytopenia. They are hard to distinguish from ITP, and the treatment is the same. OB complications, we have fetal and recurrent pregnancy loss. 15% of the patient with recurrent pregnancy loss test positive for APS. And 15% test with recurrent loss test for positive for APS. 50% of loss occur after 10 weeks if you have APS. Also, we can have preeclampsia with APS. 15% of patients with preeclampsia can test positive for APS, especially if you have severe preterm preeclampsia less than 34 weeks. Also, these patients can have FGR. 20% of APS patients can have FGR. So if you have recurrent pregnancy loss, there's a 15% chance of you having APS. If you have preeclampsia, also 15% chance you have APS, especially if you have severe preeclampsia before 34 weeks. Management depends on if they had a history of VTE versus no history of VTE. So if they had a history of VTE, usually we start them on a therapeutic dose of heparin, usually molecular weight, during pregnancy and then 6 weeks postpartum. Then we switch them to warfarin. Aspirin is started at 12 weeks. Without a history of VTE, but a history of prior pregnancy loss, patient is started on prophylactic dose of low molecular weight heparin and also aspirin. This can reduce pregnancy loss by 50%. We will increase surveillance in the 3rd trimester. Obviously, we avoid combined OCPs, but progestin-only pills are okay. Here's a algorithm for the management of APS. So pregnant or postpartum women with persistent APS, we ask if these patients had a VTE event in the past. If yes, then during antepartum, they are started on therapeutic dose of low molecular weight heparin plus aspirin. Postpartum, they are on warfarin indefinitely. If these patients never had a VTE, then we ask them if they had APS defining pregnancy morbidity. Then if yes, and they had 1 fetal loss at 10 weeks of gestation or 3 unexplained consecutive spontaneous pregnancy loss less than 10 weeks gestation, then these patients will be started on prophylactic low molecular weight heparin and aspirin, as well as postpartum. If they had a preterm delivery of a morphologically normal infant before 34 weeks due to severe preeclampsia, eclampsia, or other findings consistent with placental insufficiency, these patients are on just low dose aspirin. However, postpartum, if they had a vaginal delivery, they will continue on aspirin while in the hospital. And then for another 6 weeks. If they had a C-section, then they will be on low molecular weight heparin and aspirin for 6 weeks. If this patient never had a pregnancy-associated APS, then in the antepartum period, they are just on low dose molecular weight low dose aspirin, but postpartum they are on aspirin, and then after C-section they're on prophylactic dose of molecular weight and aspirin for 6 weeks. So these two are the same. So if they had a delivery before 34 weeks due to preeclampsia, the treatment is the same as if they had no issues, no pregnancy defining morbidity.